Good evening, everybody, and welcome to this London Clinic lecture. My name's Roger Kirby. I am president of the Royal Society of Medicine, and it's my pleasant duty tonight to introduce to you Christopher Peters and Professor Roger Kneebone. Roger Kneebone's a clinician and educationalist whose research builds on experience in surgery and general practice and his interests and expertise beyond medicine. He's passionate about engagement in bridging the worlds of clinical practice, biomedical science, patients, and society. He leads the Imperial College Centre for Engagement and Simulation Science and the Royal College of Music Imperial Centre for Performance Science. He's also a professor of anatomy at the Royal Academy of Arts. Christopher Peters went to medical school in Leeds and stayed there to complete his junior surgical training. After a fellow job in King's College, he moved to Cambridge to do a PhD with Professor Fitzgerald. After returning to London to complete his higher surgical training, he was appointed as clinical senior lecturer in GI surgeon at Imperial College London. He's got an academic interest in biomarkers and in particular understanding why there's a disconnect between biomarker studies and that are generating novel predictors of disease in the clinical world where patients are actually treated, and why there are very few biomarkers that have successfully transitioned to the point of widespread use. He's also interested in the uptake of new surgical techniques. And so I'll hand over now to Roger. I think you're going to share your screen, Roger, and take it from there. I think we've got about 400 people registered for the meeting, so do ask some questions. We'll try and get to those after these talks. Thank you.
Well, thank you very much, Roger, and it's a great honour to be invited to deliver this London Clinic lecture at the Royal Society of Medicine, and to do so in the company of my friend and colleague Chris Peters. I'm going to just start off by setting the scene just for perhaps 10 minutes, looking at this whole issue of robots and surgeons, and thinking not so much about where are we now and where we're going to go next, because that's what the bulk of this lecture with Chris will be about, but thinking where we've come from. So it's just over 100 years or so ago since this painting of surgery in a casualty clearing station in the First World War was painted. And it gives a sense of surgery, of people clustered around a patient, anaesthetic machine, instruments in the foreground, that I think is very much part of the way that people often think about the world of surgery. Very different in many ways from robot-assisted surgery, where we have the surgeon not dressed up in a gown, but sitting at a console over there on the left of the picture, and the patient in another part of the same room, although it could be another room or indeed another country, with the rest of the surgical team around the patient. And so I think this idea of an arc, of an innovation, is an interesting one to think about, because we see it again and again, that something that is extraordinarily new quite soon becomes normal, and then not long after that seems old and is supplanted by the next new thing coming along. So I thought I'd just spend a couple of minutes thinking back to my own experience. Now, I wasn't born when King George VI, the Queen's father, had his pneumonectomy, had a lung cut out, or part of a lung removed for lung cancer. And for a long time it never occurred to me that this was anything other than ancient history in the history books. But a few years ago I had the privilege of meeting Miss Sarah Minter, who for a long time was the senior theatre sister at the Westminster Hospital. And I talked to her about that time. And she told me about the day when Mr. Clement Price Thomas, later Sir Clement, came into her office and talked to her about it. Here's what she said.
He came to me one Saturday. I mean, I didn't know the King was there, and he said, shut my office door, and he said, I have to operate on the King. Told me what I had to do, and he said the authorities of the palace won't allow him to go into hospital. They said the King can't go into hospital, and so we've got to do it. Would you set up an operating theatre in Buckingham Palace? I said, well, if that's what you want, yes, sir. I mean, we didn't argue.
And I think this says some very interesting things about surgery at the time. Now, Miss Minter died a couple of years ago at the age of 100, but I think this gives a very vivid glimpse not only into the fact that at that time the king had he had to have an operating theatre set up in a bedroom at Buckingham Palace because it was considered impossible for him to go to a hospital, and that very different social sense of the members of a surgical team, Miss Minter saying, well, you didn't argue in those days. And so I think there are an awful lot of interesting things we'll pick up later about not only about technology but about how people work together. Now at that time, of course, we were talking about open surgery. When I was a medical student, when I was training in surgery, it was all open surgery, this kind of thing that I showed you at the beginning. And for a long time, this was kind of standard. So several decades after that painting, a brief glimpse of Mr. Mortimer Wolfe carrying out a cholecystectomy, an operation to remove the gallbladder, very common operation, usually for gallstones. And so here in the first part of the 20th century, we see Mr. Wolfe carrying out an operation where he has opened up the patient, looking directly into their abdominal cavity. He's dissecting structures, he's tying a ligature around a duct or whatever. And it seemed at the time that that was how surgery had always been and always would be. And when I was a medical student in the 70s and a surgical trainee in the 80s, it was very much like that too. Here's another brief glimpse of that same operation, this time carried out by Professor Harold Ellis, whom some of you may know, who at the time was the Professor of Surgery at the Westminster Hospital. And it's rather a similar story.
I'm going to demonstrate in this presentation a cholecystectomy on a middle-aged lady with multiple gallstones. The peritoneum opened over the duct system, carefully dissected away, and this is helped by a Leahy swab. So
again, very, very similar to that operation I showed you from several decades earlier. But although it seemed as though things had always been like that and always would be, that apparent stability turned out to be just on the cusp of convulsive change, because this was coming to the middle, towards the end of the 1980s. And coming up behind the open surgery that I've mentioned was keyhole surgery, pioneered by a number of extraordinary people, some of whom I also had the privilege of getting to know, particularly Mr. John Wickham, the urologist. There he is up at the top left with his theatre sister Tony Raybould on the top right, and a number of his colleagues below. Now, Mr. Wickham died a couple of years ago at the age of 89. But he was one of the pioneering spirits who thought there must be a better way to do surgery, particularly in his field of stone surgery in the urinary tract, than making a big incision into somebody to get access to the kidney or the ureter. And he pioneered with colleagues the idea of making feeding a tiny wire under X-ray control into the right place, and then in this case putting in an instrument that he himself had designed to take out the stone without having to make a big incision. And that, I think, paved the way for a completely different way of looking at things. And now if you have your gallbladder taken out, for example, it will almost certainly be done by keyhole surgery. You will have tiny instruments put into your abdominal cavity, little cameras, and the surgical team will be looking at what they see on a screen. But that too was on the verge of change. And in September 2000, I was invited by Professor, now Lord Darzi, to join him in the operating theatre. I'd just become a member of his team then, of his research group, to see him carry out the UK's first robot-assisted laparoscopic cholecystectomy, so keyhole surgery operation, but carried out using, in this case, the Da Vinci robot. At that time, it was the only one in the UK. For a very long time, it was the only one in the UK, and it seemed like something from outer space. The surgeon, as I showed you earlier, sitting over there on one side, the patient on the other. And yet, only 17 years later, in 2017, I was invited to curate an event at the London Science Museum with a group of 300 people who came to watch Lord Darzi reenact that operation from 17 years ago, with Shirley Martin over there in the background, his theatre sister at the time, because that Da Vinci robot, which had been the very latest thing you could imagine in 2000, had just become an acquisition of the Science Museum. It had become an object that formed part of the Science Museum's collection. And I'm just going to show you a brief glimpse of that enactment, where Lord Darzi explains how he used that instrument the first time in that operation.
That we used in open surgery, a scissors, no different than the scissors you have at home. So we use these inside through a big incision. We cut whatever we have to cut. We substituted those with exactly the same instrument, but about a foot longer, but fine, so it goes in through a tiny hole. That is what we call keyhole surgery. Then came the robot instruments, and you're going to see these working. These start moving into all sorts of different directions, so they have exactly as what the human wrist movement is. We call those 6-degree freedom of movement, so you can actually simulate the whole human wrist, where with this one, there is no human wrist. It just rotates that way. It doesn't have any tip at the end that turns around. So first of all, you switch on the robot, and the two instruments, I hold them. I don't know if you're going to see them on the camera. They're like two tweezers, yeah? So, I don't know if you're seeing the picture. So that's the liver.
Yep, we're seeing the picture.
That's the gallbladder, which has bile. If you've had a rough night, we'll know what a bile is. The gallbladder drains through a tiny duct here, which we call the cystic duct, into the bile duct here. So during the operation, you need to be very careful. You don't damage any ducts in here, because that won't be good. Now, do you remember what I said to you about the 6-degree of freedom of movement? You can see how these instruments are moving.
So we'll leave that there, and I should point out, of course, that this is a simulation of an operation, not a real one, but it's a realistic simulation that showed how that instrument was used. And so I think this again points out that process of perpetual change, where something that is very new becomes something normal and then eventually becomes in its turn old, which is really going to be the starting point for this conversation, because I think robot-assisted surgery has made a bit of a change from being extraordinarily new to beginning to settle down, and who knows where it may be going next. We can tell where it's come from, but we are still exploring where it might go. And so on that note, I'm going to introduce my friend and colleague, who, as you have heard already, is a clinical senior lecturer and a consultant upper gastrointestinal surgeon with a particular interest in cancer operations for the gullet and the stomach, and does many other things besides. So it's a great pleasure to introduce Mr. Chris Peters. Chris, over to you.
Thank you very much, Roger. If you could bring up my first slide, that'd be fantastic. So I'm going to just briefly go over the sort of fundamental differences between laparoscopic or keyhole surgery and robotic surgery in just a couple of slides, just to give us a frame of reference for the rest of the conversations. But some of this has already been sort of briefly covered. The key thing with laparoscopic surgery is that you're operating across the abdominal wall using long fixed instruments that, generally speaking, will open and close, will rotate, but you are using them using the abdominal wall as a fulcrum. So when you move your hands up, down, left, right, the instrument moves in a corresponding manner inside the abdomen, and you watch it on a TV screen, which is normally two-dimensional. Whilst there are three-dimensional laparoscopic surgery sets, they're not particularly widespread in the NHS. So this is a two-dimensional process of using rigid fixed instruments. In contrast, if we move to the next slide, please, Roger. The robotic surgery systems work in a different way. Firstly, they're operated from a console away from the patient by the consultant surgeon operating. He has the controls he holds are, generally speaking, very different. They are a pincer grip that you put your fingers through, and you manipulate them and can change the angle of them by rotating your wrists and by opening your hands and closing your hands. But what is most different is the robot, as we call it, which is by the patient's bedside, which typically has about 4 arms that still go through the abdominal wall in the same way as keyhole. But the difference is the instruments on the end of them are controlled by the surgeon sitting at the console, and those instruments are what we call wristed. So like the human wrist, they're able to move in more dimensions and they're able to perform more dexterous feats. And the other major difference is that the imaging system in these is a 3-dimensional imaging system. So there is depth perception provided to the surgeon. Now, the key thing before we go any further, just for anyone who isn't in this field, is there is no autonomy in these robots. They are effectively a remotely operated system by a human surgeon. And this is one thing that the public sometimes get muddled. They think that the robot is doing the operation, when in fact the robot is just a remote control device that is acting as an extension of the robot, of the surgeon's hands. So if we go to the next slide, this is a video. This doesn't have any audio on it. I know there's been some issue with people hearing the video audio. So this is the Da Vinci SI, which is one of the more modern systems. You can see that the console that the person's sitting at there, this is again a simulated operation because this is used as part of the Da Vinci's publicity. So the surgeon leans forward into this console, which provides 2 screens, one for each eye. This is the robot itself with its 4 arms. And then you'll see that as the surgeon is moving, that movement is translated into the movement of these robotic arms across the abdominal cavity. And this is a nice illustration of what we mean by that wristing, which is how the instruments can rotate around multiple axes. So the surgeon is sitting there viewing the world in 3D. And then manipulating the controls with the rings around his finger that allows him to open and close. And you can get very dexterous movements. You can scale down your movements. So a large movement with your hand is translated into a much smaller movement at the instrument tip. They can even reduce tremor. And you can potentially increase the precision and quality of the surgery. Now, the Da Vinci system was via a number of companies and a various convoluted pathways spun out of a American defense program looking at creating battlefield robots. And one of the issues there was that for many, many decades, they held the entire patent on surgical robotics. So what's interesting is that it is really only in the last 3 or 4 years that we've had competitors to Da Vinci come to the market. And there's a number of these, but if we move to the next slide, one of these came out of Cambridge, so CMR used to stand for Cambridge Medical Robotics, and they've got the Versius system. And this is an example of how things are changing. So you can see that the console is an open console now with a 3D monitor that's looked at using 3D glasses. Some of these systems have changed the control mechanism to be more like a laparoscopic instrument than the robotic instruments, and the arms are arguably more sleek and more Apple in design as opposed to perhaps the Nokia of the Da Vinci system. So we will leave it there and then begin our conversation.
Well, thank you very much, Chris. That's a very interesting sort of overview of where we are now with robots. But you started off by saying that they're not autonomous; they are really an extension of the surgeon, a bit like a surgical instrument. So to what extent are they an advance, and to what extent, I suppose, are they as different from laparoscopic surgery as laparoscopic surgery was from open surgery, or is it more of a sort of gradual evolution?
So I think they can be called surgery 3.0, and that's how some people refer to them. 1 being open, 2 being laparoscopic, 3 being the robotic surgery. And I think there are, to my mind, there are 3 sort of potential benefits to the robotic systems over laparoscopic. There is the increased dexterity and the increased fineness with the movements, the articulated wrists, that ability to do more complicated maneuvers inside an abdominal cavity than the rigid instruments of laparoscopy allow. And that greater precision resulting in a more accurate operation with less risks of mistakes being made and more delicate surgery. The second benefit is the optics. And actually, a lot of people who do robotic surgery say that this, to them, is one of the main benefits. The ability to see things in 3D, the ability to understand the 3D structures that you're operating in is a big benefit over laparoscopic. But what's interesting, actually, is very experienced laparoscopic surgeons actually don't have any issue in converting that 2D picture into a 3D visualization of the abdomen. And when you're seeing trainees, that's actually one of the things you notice, is that a very junior trainee will be grabbing for something laparoscopically that you can see is 5 centimeters further away than where they are, but they haven't translated that yet. And let's be honest, most computer gamers have been doing things in 2D for a long time and having no problems with navigating 3D worlds. But I think the third point actually is one of the more interesting ones, and one of the ones which is often not thought about, which is the ergonomics. There is a surgeon stoop. You know, when you see a more senior, more elderly surgeon who's been working all of their life, they are often slightly hunched. They often have neck and back problems, and these problems can be career shortening. You know, I am aware of surgeons who have shortened their career due to severe neck pain, severe back pain, fatigue, decreases in concentration as operations progress. And the advantages of sitting in what should be a very ergonomic, very comfortable position away from the patient, where you can adjust your position easily, where you can get in a nice neutral place that physiotherapists would say or is very ergonomic, is significant. For an individual patient basis, lack of fatigue. For a surgeon basis, maybe potentially even extending their working life.
I mean, that's really interesting, and that's really going to be a lot of the focus of what we're going to be talking about this evening, because we're looking at these developments really from the point of view of the people who are using them, leaving on one side for a moment the effect on results and from the patient's point of view, but thinking from a surgeon's point of view. And I mean, to this day, I remember very clearly during my own surgical training, and I'm sure anybody of my generation will have that experience, of spending hours and hours and hours, first of all as a junior member of the surgical team, hanging onto a retractor or some piece of metal to keep something out of the way, where I often couldn't even see the other end of it.
Yeah, very character building, I always like to think.
And if it was a short surgeon and I'm quite tall, I'd be sort of bent over for hours and hours, and all that would happen if I slipped was that I'd get shouted at. And it was it was almost a rite of passage, but it was a very it could be very unpleasant, couldn't it? And then even as a leading operations and things, it could be difficult and awkward getting around corners and all that sort of stuff. So from what you're saying, that the robot assisted approach solves some of those problems at least.
Indeed it does. It's more than just the ergonomics of sitting nicely. One of the things about robotic surgery is you can clutch, we call it, the instruments in and out, which is the same as clutching a car engine in and out of the drive chain. So if you find yourself in an ergonomically poor position and your arms are off to one side and you're struggling to operate, what you can effectively do is unlink your controls to the operating instruments, reset yourself back into a more neutral position, and then reactivate the controls. So you should always be operating in a nice, neutral, comfortable position where you can have the greatest dexterity. And that certainly is not present in laparoscopic surgery. When I was a training registrar in Chelsea and Westminster Hospital, I developed a shoulder problem purely due to the odd positions I had to adopt to assist my consultant. That got so bad I couldn't pick up my new son. I started to try avoid going to theatre because I knew how much it was going to hurt me, and that was as a relatively junior trainee. When you scale those things up to surgeons operating all over the country, these ergonomics, these musculoskeletal issues really count. They really matter.
Yeah, because I mean, I think certainly with the kind of open surgery that I was trained in, I know a lot of instruments were designed specially so that they would fit beautifully into the hand or whatever. They'd allow you to do particular movements, but they never really took into account the whole body, did they? They were just really your fingers and the effect on your shoulders and your posture and things. I don't think was ever, I certainly don't remember it ever being discussed.
No, I agree. And actually some of the open things such as retractors are almost designed to hurt your hands. You know, they've got sharp edges and they're incredibly uncomfortable to hold. So no, I completely agree, Roger.
So when I was doing open surgery, then a very big part of it was getting the feel of tissues, and you know, those tissue planes and those sort of ways of separating organs. And for people who are not surgeons who might be listening, that kind of surgery is very tactile, and it involved getting a lot of information about not only which organs I was working with and where they were, but also the state of them, you know, how healthy they were, how hot or cold they were, how springy they were, how you know what happened when you pressed them, if the blood came back into them, all that kind of thing. So what about that side of things when you're operating at one remove?
You're exactly right. So with laparoscopic surgery, if we talk about that first, there is a degree of tactile feedback, but the tactile feedback is being passed on to you via a slightly springy, long instrument that dulls it to some extent. So you can to some degree feel the firmness of the structure you're on, but more than anything, you can kind of feel how hard you're pulling, because that's being translated to you via the fulcrum on the abdominal wall. The first robotic system that came to market, the Da Vinci system that we've shown the videos of, and we've shown Professor Lord Darzi operating with, actually didn't provide any tactile feedback at all. It's operated by a system of pulleys, so strings and sort of cogs effectively, and therefore there was no tactile feedback. And actually what surgeons who use that system learn to do is interpret the visual clues that they're getting of how the instruments are manipulating the tissue to create a kind of almost pseudo haptic feedback in their mind, that they can sort of see that the tissue is not so yielding. They can see how to tie the knot, and knot tying is a classic example of this, because anyone who's tied a knot open will know that you can feel on your hands the tension to put on the string to get it to come together nicely and to not snap. And actually, when you start using the robotic systems, it's like becoming a baby again, and you'll often be snapping the suture because you're pulling too hard, you're pulling in the wrong direction. What's interesting is that I talked about some new competitors coming to the market over the last few years. And one of their advantages that they are pitching is the introduction to haptic feedback. So there's a system by a company called Transenterics. And one of the things they do when they're demoing their system is get you to pull a rubber band apart to give you that sensation of the haptics. And the theory is that the haptic feedback will improve the safety, because you will feel when something is going wrong. You will feel where perhaps you're pressing too hard on a trachea, as an upper GI point of view. We're peeling the esophagus off the trachea, and the trachea is a relatively delicate structure. And if you can feel the tension you're using and you can feel those tissue planes, then perhaps you're less likely to damage the trachea.
So is this like, I mean, the trachea, that's the windpipe, isn't it? I mean, it's
yes,
quite delicate structures around there. I mean, certainly in my experience, I would often sort of put my finger in and see what things felt like, and see how much give there was.
Exactly. Or as I refer to it, the consultant's finger. So when the registrars are doing the operation and you're frustrated by their progress, you say, can I have a little feel? And then you do 90% of the work with a little sweep of your finger, and suddenly you're a lot closer to having coffee.
So can you get closer to coffee using the robot in the same sort of way? Can you nowadays gauge how hard you can press and things like that, and do stuff that you used to be able to do with your finger? Or is it still too mechanical?
So with the Da Vinci system, what people will argue is what you lose in terms of your finger, you gain in terms of a 3D view from much closer to the structures than you could ever get by standing outside of the patient. So you are right up close to the structure. You can see tiny blood vessels, you can see tiny structures, and the combination of the vision and the articulation of the instruments overcomes the lack of the finger, the tactile feedback. What the makers of the new robots coming to market, who are pitching their haptic feedback, their tactile feedback, would say is that they then add that on as well. So what will be very interesting to see is that whether that improves take up of these systems or opens them to use by people who are previously sniffy about it.
Well, we'll come on to think about how you learn to use these things in a minute, but I just wanted to ask you a little bit about that sense of, that change in the balance between touch and vision. And you've talked about things being, greatly magnified, and you see tiny little things. Is there a sort of danger of confusing the wood, not seeing the wood for the trees? If you get so close to something, can you, I don't know, lose your bearings, or think that some things are more important than they actually are? I don't know. Does it distort your sort of inner sense of what human anatomy is like?
Yep, that can be true, and actually, with open surgery, you can have that instant view of the entire operative field. And actually, one of the important things is where there are 2 or 3 of you gathered around the table, which is the norm. Other people may notice something off target that you haven't noticed, that you're trapping a bit of bowel, or that potentially something's going to get caught up that shouldn't. Laparoscopic surgery, you lose that to some degree because you have a narrower field of view, but laparoscopic surgery, it's relatively quick and easy to go in and out with the camera and move around with the camera. With the robotic surgery, the camera tends to be a bit more fixed in position and tends to move a bit more slowly. And you're exactly right that what you need to be very careful about is that your operative instruments are in view and you're aware of what you're doing, and particularly the ones where you're lacking haptic feedback, that you're not doing off-target damage because you've got an instrument that you can't see, or that's on the limits of what you can see, that's doing something it shouldn't be doing. Or even with the robotic surgery, you normally have an assistant at the table who may be having a standard laparoscopic instrument helping you move stuff around and holding stuff back, the equivalent of the junior trainee standing there with the retractor. And again, you've got to make sure that they're not doing off-camera damage that you can't see. So that's a very good point. You have to have more situational awareness, really.
Yeah, so that brings me to the whole question of the surgical team. I mean, talking about the early days with Miss Minter and the King's lung operation, and then looking at these. Well, right from the earliest pictures I showed, this was people standing around, wasn't it, close to one another, able to read one another's bodies and sort of interpret one another's movements, and all looking at the patient. But those pictures I showed of those bigger pictures of the operating theatre with the robot, the surgeon was in one place and a whole lot of other people were in another. So does that raise issues about communication within what would otherwise be a physically pretty compact team?
It does. The Da Vinci system in particular has a microphone built into it, interestingly, but the surgeon is actually quite isolated. They're in a hood almost. They're quite isolated from the rest of the operating theatre. And actually, it's another way that some of the other newer systems coming to market are differentiating themselves, because they're more open and you're more able to see what's going on. The issue of training is a very important one, because the standard Da Vinci system includes one console and one robot, and therefore only one surgeon at a time is getting the stereoscopic view and is controlling the instruments. There are training systems that come with two consoles, but as one can instantly imagine, that adds massively to the cost. And therefore the question is, how do you train people on this? Because as you say, if you're training an open operation, it's incredibly straightforward. Both your hands can be there at the same time. If you're training a laparoscopic operation, it is very easy to take over, to reach over, to adjust, to show and to point. When you're training robotically, then there is it's a more complex step to switch unless you have one of these dual console systems. The credentialing required for these robotic systems is very high. The companies have done an awful lot of work in terms of ensuring that surgeons are appropriately trained, using animal models, sometimes cadaveric work, doing proper preceptorships and having sort of mentoring through their first X number of cases. But that often is directed at the consultants. And therefore the question is this going to freeze out registrars? So the sort of most senior group of trainees who are waiting to be consultants. How do we make sure that these registrars are being adequately trained on the robots? Because I have to say, in the current situation, in many situations, the surgeons who do robotic work have developed that skill set as a consultant. And actually, even at the moment, there are relatively few robotic fellowships compared to, say, colorectal fellowships. And there's relatively few people coming through who already have those skill sets. So
talking about that then, because I mean, this conversation is it's about the learner's perspective as well as the teachers. Are you saying now that that at the moment, people who become robotic surgeons, if you like to use that word, have switched over from something else? They've switched over from being laparoscopic surgeons or even open surgeons? Or are there some people who've been, so to speak, raised in captivity and have never known anything other than robotic operating, if that makes sense?
So I think this trend has been happening for a while. In cancer, the vast majority of us have still trained in open techniques, because there are cancers that for whatever reason you can't approach laparoscopically using the sort of technologies or robotically. So I think in cancer,
Sorry, Chris.
Yeah, I'm ever so sorry.
Lost you.
I think my connection went dodgy there. Where did I cut out? Did I cut out at the discussion about cancer surgeons?
Yeah, for me, you started off by saying that that surgeons that you have to be able to go back to or go to open surgery sometimes because some of your cancer patients need that, and then you cut out.
Yeah, so whereas in benign surgery, there are surgeons who have done most of their training and most of their operating keyhole, and some of them would accept that actually when they're necessitated to go to open, they are less confident and less happy about that. Robotic surgery, again, is generally speaking the preserve of the enthusiast and someone who's got a great deal of experience. And in my experience, those people often have a great deal of open experience as well. I suppose, you know, historically, we've always began with our surgical training as being open procedures and open hernias, then going to keyhole hernias, for example, you know, open bowel resections, going to laparoscopic bowel resections. So whether we'll come to a time where we'll de-skill totally as open, I don't know. I think it'd be a dangerous thing to come to.
I was going to ask you about that, whether there will come a time when the new, as it is now, becomes so much the sort of norm that we'll have. I mean, there are a whole lot of techniques that people used to use in the old days that we no longer feel useful. You know, I just wondered where you think we might reach that point where this kind of way of doing things that is clearly developing so quickly will become so much the norm that's all people know in their training.
Yeah, that's a very difficult question. I think at the moment, I think a lot of us could always think of an event that could happen in robotic surgery, like a major hemorrhage or something very serious, whereby you would necessitate a very big cut and very quick access. But as the technology improves, that may become less important.
I mean, isn't there an argument from the point of view of the skills of the surgeons that, I mean, you know, making a big incision and dealing with somebody with big bleeding is quite a tricky thing anyway, even if you're used to it. If you hardly ever have to do it, and only occasionally when it's really bad, then isn't that putting you in quite a difficult position?
Yeah, no, I agree. I think it was interesting. I was actually having a conversation with my children who are 10 and 8 the other day about autonomous cars. And my daughter wondered whether she'd ever need to learn to drive a car, because she said, you know, if cars are driving themselves by the time I'm a grown up, will I ever need to drive one? And I suppose that made me think, well, that's interesting, isn't it? Because if something goes wrong, do we have to train all these people to take over themselves, or can we rely on the autonomous cars? I think it's interesting. I think that there will be an array of surgery, such as trauma surgery, where absolute speed is required, and you know, in a true trauma situation, you need to get into the abdomen within seconds, and the robotic setup time will never be quick enough to do that. You know, you'll never be able to get into an abdomen as quickly with a robot as you would in a trauma situation with a big pair of scissors. So I think there will always be a role for open surgery in training. Whether we become more and more specialized to the point of view that we have people who are siloed into being pure robotic and therefore they lack those open skills, I don't know. But I think it might, at the moment, I think that'd be a dangerous game to play.
So you talked about your daughter and the driverless cars, and you started off by making it very clear at the beginning that this was robot-assisted surgery. This wasn't robotic surgery. But will we be having driverless robots soon? I mean, you know, or surgeonless. To what extent is the robot simply an extension of your hands, and to what extent will it be able to do things?
Yeah, this is always dangerous because I think a lot of us, I think every profession in the world would like to think that a robot couldn't do their job until a robot comes and does their job. As I mentioned, at the moment, these are remote controlled systems entirely managed by the surgeon. The next level will be AI augmented, and by AI augmented, and this is what people are talking about at the moment, there will be the overlaying of extra information on the view that the surgeon gets to improve the precision of their surgery and improve what they're able to do. And in the simplest form, this would be taking a CT scan or an MRI scan that the patients had before their operation and overlaying that 3D information so that, for example, if you're a liver surgeon, you can see where the liver is, see where the cancer is hidden inside the liver, even though it's not visible under white light. So you augmentedly lay that on. Now, once you start being able to do that, you can potentially have systems which improve safety and improve precision. So for example, the gallbladder surgery that you saw the open operation of, you saw the keyhole operation of, you saw Ara doing a robotic simulation of, there are major structures around there that is vital that you don't damage. The bile duct that drains the liver, if you damage that, that is a catastrophic and can be life-shortening complication. So you can imagine a system whereby doing a robotic operation, you could overlay that anatomical information to warn you that you're getting close to a structure that you may not be able to see. And then you could actually go further, and you could have it audibly warning you you're getting too close. You could even have it stopping you temporarily if it thinks you're going to divide that, to make you reconsider what you're doing. And that's the kind of equivalent in cars to lane departure warnings, to like the Tesla semi-autonomous systems, whereby it can follow another car at a set speed, and it can even change lanes on its own. But at the moment, it couldn't navigate Piccadilly Circus.
So might that be a sort of partial solution to the training issue? I mean, could you set up sort of safety barriers beyond which, I don't know, a trainee wouldn't, but the machine wouldn't allow it to go if it was approaching delicate structures or important things that were important to avoid? Could you as an experienced surgeon work in concert with the technology to develop educational approaches for teaching younger people who haven't got the experience that you've got?
Yeah, so this is a very good point. So surgery is about pattern recognition. And what's very interesting, now I'm a relatively junior consultant. I've been in post for 4 years, but then I work with people like Professor Hannah, who are much more experienced than me. And what's very interesting is that your ability to recognize patterns continues to grow with your experience. And I will see tissue planes. I will see where we need to divide next, that my registrar might not see, because they haven't learned those patterns. They haven't learned those very subtle differences in texture of tissue that give us that idea of where we're supposed to be going next. So I suppose the question is, will an AI augmented reality system give that pattern recognition skill set to a more junior surgeon, and perhaps give them some of the advantages of recognizing the structures to avoid, recognizing where they need to be going next, without having to wait for that decades of experience to give them that. And I think that's that potential safety aspect of AI augmented robotic surgery is potentially very powerful. So identifying where the bile duct is in the keyhole operation is something we all hope to be able to do, but there are a significant number every year across the world of bile duct injuries. So therefore, it is not a perfect system. If you could use AI to give a more novice or a more junior surgeon the advantages of that pattern recognition, then that would be that would potentially make that surgery safer.
And I can see that. That's very interesting. I mean, in the closing minutes, because we're getting towards the end of our time, I think I wanted to just ask you about something else. You talked about different countries, and you've talked about these new robots that are coming on. But presumably, unlike I mean, when I was doing open surgery, if I was using an instrument and a different instrument came along, I could try it out. If it didn't work, it didn't cost all that much. But if a hospital, say, has invested in a Da Vinci system or something, and then 5 years later or 2 years later something much better comes on, is there not a sort of move to stick with the old or the older, and for either for financial reasons or for other reasons, to sort of lag behind what the technology could offer?
And I think that's another interesting point. And I think the Da Vinci system has been interested because of its dominance of the market by the patent issues that I talked about previously. So though they had various iterations of the system, it was a reasonably stable platform, but they did still quite aggressively encourage updates, and lots of hospitals raised charity funds to update their Da Vinci systems to the SI, etc. some of the new robotic companies are actually working differently to this. They're actually offering a license type system for exactly this reason. So the idea is you're licensing your robot, and then you'll get the upgrades, you'll get the software upgrades, you'll get the technology upgrades to try and keep it current. So that is, the laparoscopic kits are modular enough that in reality, if you have a good quality screen and a good quality light source and a good quality carbon dioxide source to inflate the abdomen, then actually you can change out the camera, you can change out the instruments, you can change the other bits of it quite easily. Whereas the robotic systems are more fixed, but there's still the ability to introduce new instruments or new what we call energy devices, so things that seal and things that cut. So there's still the ability to incrementally upgrade, but the massive outlay at the moment for these systems, in excess of $1 million, means that the funding decision is more complex.
Because I was thinking that if all these advantages are being developed, it sounds from what you're saying as if once people start focusing on the experience of the surgeon, as opposed to the results, as well as the results of the patient, of course, but in terms of what it is like ergonomically, and you were talking about having a clutch that allows you to reset things. As these developments come along, then presumably some of them will require quite major changes to the technology.
Indeed, yeah, or entire new systems, yeah, exactly.
I'm sure people listening will have a lot of questions about where things might go next. So I'm going to finish by asking you, from where you are at the moment, what do you see as the big things on the horizon that are going to change in the next few years?
Yeah, I think the integration of augmented reality technologies and AI will be another massive step forward. And in fact, there's a company called Verb, which spun out of Google and Ethicon Endosurgery, which is a very big surgical equipment company. And they are the ones who call this surgery 4.0. Because they distinguish it between, like I mentioned briefly earlier, 1 being open, 2 laparoscopic, 3 being robotic, surgery 4.0 being augmented reality, big data driven surgery. And I think that will be a game changer potentially in terms of increasing the dexterity, increasing the precision of surgery, and perhaps decreasing the risks for patients and shifting the bell-shaped curve almost, so that the average surgeon maybe can perform more like the higher end surgeons who have that greater level of experience or skills.
And so are we going to see the Science Museum filling up its shelves with robots that have come in as a sort of space age answer, and then
they may well do, but I suppose they probably want to keep the original robot as the prime thing. So I suspect they won't want every robot that comes out, otherwise they'll need to build a new wing.
Okay, well, thank you very much, Roger Kirby. I guess we've come to a point where perhaps we should be opening things up to questions and ideas from the audience.
Yeah. Well, thank you very much. That was a brilliant conversation. I'm sorry about the glitches. I was in touch with Victor, our excellent technician. He thinks it's some kind of Zoom glitch that's going on, and we lost Christopher for a minute or two. But that's one of the challenges of dealing with virtual lectures. So apologies to the audience and apologies to you guys. Well, we've got a question from Ben Chalicum, who's a robotic surgeon at Guy's, probably one of the most experienced robotic surgeons in London, who's like me, a urologist. He says, I think the question for you, Chris, which of the new competitors will gain the greatest market share? Is it going to be the one with the best AI, or will it be the cheapest? Because the cost constraints are going to be rather important, aren't they, in the future?
That's a very, very good question. So we were fortunate enough to be the first UK test bed for the transenteric system, and one of the benefits of the transenteric system that they highlighted was the fact that you licensed that you bought the system off them, but then they didn't charge per case, therefore it made it very, very cost effective. But we found there was limitations to the system that meant that we didn't really think it was going to surpass the Da Vinci in our eyes. I think one of the big issues is going to be the add-on stuff that you use surgically. And what I mean by that is that we don't just use scissors and graspers and things that cut. We use stapling devices to divide things and join things up, and we use energy devices to dissect things safely and to seal vessels off. And my feeling is that a company like CMR, which are a pure robotics company, may have more of an issue by being able to offer these add-on devices compatible with their system in terms of staplers and energy devices than a company like Ethicon Endosurgery or Covidian, who inherently will design their robotic platforms to be compatible with the tools that surgeons use. So my feeling is that it will be difficult for some of the smaller players to beat the bigger players, which is always the case. And my feeling is that therefore the one that I think is quite exciting, which should be coming to humans fairly soon, is the Verb system, because it includes the AI and the computer experience of Google with the surgical technology platform of Ethicon Endosurgery.
Yeah, that's a good answer. Roger, you were around when laparoscopic surgery was introduced with Lord Darzi and so on, and I remember there were quite a lot of complications when it first came into play. Maybe more in America than here, but quite a lot over here, and a lot of litigation. I mean, do you think that robotic surgery has been introduced in a safer way than laparoscopic surgery was?
Well, I wasn't doing surgery, at the early days of keyhole surgery or robotics either, but looking at it from the outside, I do think that an awful lot of lessons were learnt from some of the very unfortunate things that happened in the early days of keyhole surgery. I think my sense is that people simply didn't realise how different it was from what they were used to, and the sort of first wave of people or second wave of people who took it on saw it done by people who had actually spent a lot of time developing the skills and learning to deal with the things that went wrong and the bleeding and the not knowing where you were, and they made it look pretty simple. And then the people who took it on, who hadn't had all that experience, often found out that it wasn't nearly as simple as it looked, and that's when quite a lot of the problems came about. I think a whole lot of things were put in place after that. I know a lot of them probably put in place by people who are watching at the moment, and certainly Darzi, for instance, did a lot of work, didn't he, in setting up training programs and things for laparoscopic surgery. And my feeling is that a lot of those lessons about not taking for granted stuff that actually requires a lot of new skills have been learned in the robotic area. But Chris, what do you think about that?
I agree. I think there is a major danger with any new technology, surgical procedure, or robotic surgery. There is always an issue that the people who publish the first data are people who are technologically minded to develop something new or to try something new, are often in centers of excellence whereby they are audited very carefully and have very careful reviews of their outcomes and their results, and therefore they are developing this technique and performing this procedure in the best possible setting, in the most controlled setting, in the most assessed setting. And then the next wave are people who are introducing this into, so if we think about European-wide, into private hospitals where there's less oversight, without the same checks and balances, and therefore there may be a higher complication rate. And we see this actually even in robotic surgery. So in esophageal cancer, people are doing robotic esophagectomies. And if you look at the data sets, the leak rate from the join is significantly higher in the robotic case series than in open surgery, to the point where some sort of UK groups' eyes begin to water when they look at this European data and say, if I had a leak rate like that in my institution, people would begin to say, I need to rethink what I'm doing, etc. But what they would argue is it's kind of a hump you have to ride, and that when you get to enough cases, your leak rate comes down. And that's we talked about the public's exception of this in previous events that we've done, and I think this is the interesting thing with the public is actually saying to the public, you're willing to accept that you might be part of that learning curve, because someone has to be. Not everyone can be at the tail end when you're super skilled.
Okay, well, there's a question from Andrew Montgomery. Thank you, Andrew. This is a really interesting question. How would you advise surgeons in developing countries that don't have access to these advances? I mean, that is a big issue, isn't it?
That's a brilliant question. In fact, Roger and I were hoping to bring that up ourselves, but we ran out of time. It is a very good point, because the problem with these systems is not only are they phenomenally expensive, they are technically very, very delicate, and they require a great deal of maintenance. They require a lot of looking after as devices. You know, they're not a pair of scissors that can be sharpened, and they're not even a laparoscopic system, which is comparatively straightforward, comparatively few moving parts, and therefore a laparoscopic system could be placed in a developing world hospital and be reasonably reliable. These things are not inherently stable things. So I think that there is a huge potential for there to be a economic divide with these devices, whereby they are a luxury in a developed country healthcare system that's well funded, which may not be the NHS, frankly, but might be in other systems, and that they are an unaffordable luxury, or they are infrastructure impossible in the developing world. So I suppose there the question comes is, are they something which is nice to have that makes the surgeon more comfortable and maybe makes hospital stays shorter, in which case do you argue that actually the cancer outcome can be equivalent without the bells and whistles? Or do they become demonstrably better than open surgery, in which case the democratization of them is going to be important? And whether that democratization is frugal innovation tech pathway, which is a big thing at Imperial, and developing systems which offer the benefits in a more robust, reliable way, or whether it's technological advances improve to the point where the expertise to maintain these systems exists in all hospitals. But I think that they are a luxury at the moment, and it's difficult to see them not being a luxury for the foreseeable future.
Chris, can I just ask you one other point? In the early days of the robot, the Da Vinci and things, one of the much sort of trumpeted things was that you could have a surgeon in San Francisco operating on a patient in Helsinki or something, and the greatest living expert the world had ever known on whatever it was could be operating across countries or continents. Is there anything in that, or?
Yeah, you see, that's fascinating, because that's what they're invented for. So DARPA, the American Defense Agency, invested in these as a battlefield robot. The idea being that you could keep your expensive surgeons safe and sound in the US, and you could dump a robot on the battlefield to save the soldiers' lives. And it failed because it's incredibly complicated to set up. It requires such an infrastructure to set up. It's easier just to put your surgeon at risk and dump them in the field. There are every now and again these kind of very media friendly examples of a surgeon operating across the Atlantic and doing something, but they are gimmicks more than anything. And the vast majority of robotic surgery is done by the surgeon in the same room. And that's because really the institutions that have the robot surgery and have the infrastructure to do robot surgery will inevitably have the surgeons capable of doing the operations. You know, it's a very strange setup if you have the robot but don't have the surgical expertise. And a number of people I noticed on the chat actually have been asking about COVID times and whether it has a role in COVID times. And in a similar way, no, because really the surgeon is sitting at the console almost always, well over 99.99% of the time in the same room. And actually, if you think about the wider team, the anesthetics, the scrub nurse, the assistants, they're all standing by the patient exactly the same. So there really hasn't been a thought of using it like that.
See, sometimes people think that actually, just a machine does it, but actually, have I got this right? You need the same kind of team. You need people to put these instruments into the patient and make that and hook it up to the robot, and all that has to be done in the same way as always. It's
exactly. You're effectively removing one person from the operating table. It's the primary surgeon is not at the operating table, and really otherwise you have a very similar number of people at the operating table, which is interesting because actually for the COVID point of view, just to signpost people to look at it, the Microsoft HoloLens, which is another augmented reality technique, has been used by one of my colleagues, James Kinross, to de-risk COVID ward rounds, because one person can do the ward round with the HoloLens in situ, and the rest of the team can sit in a separate office, see what's happening, review the results, review the patient's examination findings, without putting themselves at risk of being on the patient. So there are technologies, but it's not this HoloLens. If you look it up, there's some very nice stuff about that at the moment in the media.
Chris, I'm going to have to stop you now. It's a shame because we've got some good questions. People wanted to know whether robotic arm was really a misnomer, and in fact, it should be a mechanized arm. Other people were asking about whether robots could be used for brain surgery and cataract surgery and orthopedic surgery. But I think we're going to have another London Clinic lecture to answer all those questions. So I'm going to hand over now to Satya Bhattacharya, who's going to give the vote of thanks. He's the medical director of the London Clinic. Chris, I thought that was fantastic. You answered those questions so well, beautifully chaired by the two Rogers, actually, but the Roger Kneebone did the better job, I think, than me. So over to you, Satya. Thanks very much, both of you.
Thank you, Roger, for allowing me to say a few words at the very end. I'm very grateful to Roger Kneebone and Chris Peters for doing this talk in such a delightfully accessible way for people who might not be very familiar with robotic surgery. From the London Clinic's perspective, robotic surgery is one of our key strengths and areas of interest. We were the first hospital in London to invest in a Da Vinci robot over 15 years ago. And we've just had the reinvestment this year in a new robot and launched the Robotic Center of Excellence. So in a way, it reflects how there's a huge cost involved in upgrading these Da Vinci robots, which you touched on. We are delighted to sponsor the annual RSM lecture, and we are a charity, and this is a key part of our charitable purpose to advance healthcare through knowledge. Thank you very much for making this evening possible. I'm particularly grateful to the team at the RSM for hosting and organizing the webinar. And I'm looking forward to being able to attend in person next year. Thank you all, and good night.